Good morning, everyone. Thank you for joining us today for Grand Rounds presented by Health for the World. My name is Kevin Benny, and I'll be moderating our session today. It's my unique pleasure to introduce Dr. Jim Hsieh. He's an assistant professor in the Department of Radiology at the Baylor College of Medicine and associate program director for the Neuroradiology Fellowship at the same institution. Dr. Hsieh completed his radiology residency at Tulane and Neuroradiology Fellowship at the University of Pennsylvania. He's been recognized with the 2022 Outstanding Faculty Leadership Award from UTMB's Department of Radiology. His professional interests include head and neck radiology, emergency radiology, spine imaging, and above all, neuroradiology education, which we're all thankful for. Dr. Hsieh has authored multiple publications, including a recent article on perineural spread in the head and neck cancers. So today's talk, appropriately so, is titled Imaging of Sinonasal Neoplasms. Feel free to post your questions in the chat at any time. I'll be periodically monitoring the chat and bring those discussion points forward during the Q&A segment at the end. With that, please join me in welcoming Dr. Jim Hsieh.
Thank you for the kind introduction. Today, my talk is going to be on imaging evaluation of sinonasal neoplasms. Pretty dense topic. Hopefully, I can keep it interesting. Going to try to keep it image rich. I'm going to go over first anatomy of the sinonasal, paranasal sinuses, go through the two different classification systems that have been proposed recently. These masses are typically initially evaluated with CT MRI, and I'll go over an approach and the role of imaging. And what's really fascinating about this area is typically think of head and neck cancer as, a majority squamous cell carcinoma, and it still is a majority squamous cell carcinoma in the paranasal sinuses, but there is such a diversity of neoplastic processes that occur. I've listed all the ones I'm gonna go over here, and I think that's for an area of the body that contains mucosal lining and pretty much air. There's such a variety of neoplastic processes that can occur, and a lot of advances in the last 5-10 years, especially with molecular testing, that I think it's a good idea to review and see what's most up to date in terms of what we know right now. So the paranasal sinuses are composed of 4 paired sinuses. We have bilateral frontal sinuses here in the red arrows. And then here are the bilateral ethmoid air cells divided anteriorly and posteriorly. We have posteriorly paired sphenoid sinuses, and then the largest bilateral maxillary sinuses. The WHO classification had a recent update in 2022, the 5th edition, and they, with that edition, really focused on classifying tumors that occur almost exclusively in this region. So they excluded soft tissue, melanocytic, hematolymphoid, and neuroendocrine tumors from their classification. And I will go over some of these new entities that they've described. But last year, there was a release of this international consensus statement on allergy and rhinology sinonasal tumors. This is like a 300-page article. And this includes, I think is more comprehensive. And so I will be presenting sinonasal neoplasm, starting with benign, followed by malignant, and mostly according to this consensus statement. In terms of imaging evaluations, unfortunately, there's poor specificity. There's going to be a lot of overlapping imaging patterns, but hopefully I'll give you some tools to help guide and make some decisions, and hopefully come up with a differential that is sound. And first of all, when you see a process in this paranasal sinuses, I tried to determine if it's inflammatory versus neoplastic. If I do think it's neoplastic, try to determine if it's benign or malignant. And what's really helpful with MRI and imaging is going to be tumor mapping, and you really want to help the surgeons and the tumor board in terms of staging. So on CT, imaging patterns that I'm definitely going to look for are going to be bony destruction or erosion, versus bony remodeling deficiency or dehiscence, whereas bony destruction erosion, you're going to think more aggressive malignant process, and bony remodeling deficiency, you're thinking something long-standing and it is more of a benign process. Other patterns I look for reactive sclerosis and also new bone formation. On MRI, MRI is going to be better at looking at bone marrow involvement. So looking on the T1, looking for low signal intensity. And it's really helpful for differentiating secretions from enhancing tumor. Because on CT, a lot of times you might just see opacification. And it's hard to determine what is tumor, what are just trapped secretions. And then you look at the MRI and it's a lot easier to differentiate and map the tumor. MRI is going to be better also for looking for intraorbital and intracranial involvement, and also perineural tumor spread. This is a nice article, figure from an article that's very good that came out in Radiographics last year. And here it kind of goes over what I've been talking about, looking at the margins. Benign is going to be more well-defined versus malignant will be infiltrative. Looking at the status of the bone, erosion, malignant, remodeling, benign. Is the lesion you're talking about displacing tissue planes, more benign versus it's invasive, malignant? And these are just suggestions. They're not absolute. So T2 signal, something hyperintense, more likely benign, hypointense, more likely malignant. And then restricted diffusion, I think a lot of times we think, oh, restricted diffusion, it's lymphoma, but it could be any kind of highly cellular tumor. So restricted diffusion, more, can be a malignant tumor. And enhancement patterns, if it's not enhancing peripheral, then maybe inflammatory, but homogeneously enhancing, more likely benign, versus a malignant lesion is going to have heterogeneous advancing. So here are some examples outlining the bony involvement I'm talking about. Bony destruction erosion is going to be aggressive. And for this talk, we're thinking about malignancy, but there are other things that can also do that. Osteomyelitis, invasive fungal sinusitis, granulomatous disease. Here we can see that there's a sinonasal mass on the right, and there's erosive changes of the anterior skull base. Here both seen on the CT and MRI. And this is a nut carcinoma that I'll talk about later. When we look at bony remodeling deficiency or a dehiscence, then we're thinking something long-standing. It could be a mucocele, polyp, slow-growing neoplasm, or cephalocele. And here's an example. Here we see a process that is has bony remodeling and deficiency of the bilateral curviform plates. And then we look at the MRI and you can see these areas of dehiscence where we see brain herniating through. So these are, well, more accurately, encephaloceles. And I do recognize sometimes it can be hard to distinguish between the two, but we do try to look at the overall picture and try to make a distinction between one versus the other. Here are examples of the other patterns of bony involvement I'm talking about. Reactive sclerosis, which we see with sequelae of chronic inflammation, chronic sinusitis. Here we see in the maxillary sinus the mucosal thickening, and the walls of this maxillary sinus are thickened and sclerotic. And then in terms of new bone formation, here are a couple of examples. Chondrosarcoma and osteosarcoma. We can see here this sinonasal mass has that characteristic ring in our conjoint matrix that we see with chondrosarcoma. And then here on the right here in the right maxillary sinus, we see this sunburst periostitis osteoid matrix that we associate with osteosarcoma. Now, there are some lesions that occur in the sinonasal region that kind of diagnosis begins and ends with CT. And so in terms of fibroosseous lesions, the most common is going to be an osteoma. The most common location is in the frontal sinus. And you can see that this is sharply well-marginated, dense cortical bone. The second most common fibroosseous lesion is fibrous dysplasia, and it typically has this ground glass appearance, and the MR appearance can be compounding, and the signal depends on the degree of cystic components in fibrous tissue. So here at MRI, if you were to see this lesion initially on MRI, you can see that it enhances, and sometimes mistakenly, people can interpret it or be more concerned that this is a malignant process, and then you get and so in terms of how CT and MRI are complementary, you get the CT, you recommend the CT, and you see this ground glass appearance, and you can say, oh, this is fibrous dysplasia. CT attenuation can be also helpful. So low density attenuation is going to be mucoid secretions, fluids, or polyps. If you see hyperdense contents, then you think about fungus or inspiscated secretions or blood and trauma. And then a soft tissue attenuation, that's when you think of neoplasm, scar, or thick secretions. In terms of MRI tissue characterization, retention cysts, polyps, and mucoceles are going to have increased T2 signal with that peripheral enhancement, versus when we start to see solid enhancement, we think of neoplastic processes, and they can have variable T2 signal intensity. Here is an example of a mucocele, and you can see that there's complete opacification of that right frontal sinus. You can see the bony remodeling on the CT. And it's on CT that has hyperdense contents. This is reflective of inspissated secretions, and we can see the signal void on the T2 MRI, and on the post-contrast MRI, we can see that there's thin peripheral enhancement. Now, I had talked about before that, MRI is really good at differentiating trapped secretions versus enhancing tumor, and this is a really good case of that. You can see this right nasal cavity and maxillary sinus mass. It has osseous destruction of the maxillary sinus wall, and on the CT, it's really hard to tell, what is tumor, what is trapped secretions, and then you get the MRI, and you can see that here is nicely outlined mass, and then laterally in the maxillary sinus, we see the trapped secretions. This is a melanocytic myeloma. You can see on the T1 that there is portions that have a bright signal. MRI is really much better than CT in terms of accurately predicting dural invasion. Eisen et al. Investigated this. They found that PL enhancements was 80% accurate, nodular enhancement 95% accurate, and more than 5 millimeter in thickness, 91% accurate in predicting dural invasion. So when you, let's say with this case, we can see the left sinonasal mass has eroded the anterior cranial fossa, and then you get the MRI to better look for dural invasion. Linear dural enhancement does not imply dural infiltration. It could just be reactive. So on a prospective blinded MRI review of 50 cases, they found that greater than 2 millimeter dural thickening, loss of the hypointense zone, and nodular dural enhancement was highly predictive. This was a case of squamous cell carcinoma. And then you can see on the MRI, on the T2 weighted sequence, you can see that there's loss of this hypointense zone. And on the post-contrast sequence, there's nodular thickened enhancement greater than 2 millimeters. And this was squamous cell carcinoma with intracranial dural invasion. Another thing that MRI is really good at is going to be looking at orbit invasion. And one thing I want to talk about is that One thing in the tumor boards that the surgeons have to decide is if they see something that looks like it's invading the orbit, they have to decide, okay, if I want to um, uh, completely resect this tumor, do they need to do orbit exenteration? And while radiologist is not the one making that decision, we do try to provide information to help them make that decision. So breach of the periosteum is a significant finding to report. In the bony orbit and periosteum, the bony orbit and periosteum is hypointense on all MRI sequences. So infiltration of this periorbital results in loss of this well-defined low signal intensity boundary. So here we have a sinonasal mass on the left, and it has eroded the medial and inferior walls of the orbit. And then on the here, both T1 and T2, you can see that there is this hypointense zone, but here we see a breach in that hypointense zone. So this is positive for periorbital infiltration and something that is important to report. Eisen et al. Also investigated this, and they found that extraocular muscle enlargement, signal change or enhancement had path-confirmed orbit evasion, positive predictive value 100% of the time. Orbital fat invasion had a positive predictive value 80% of the time on MRI and 86% on CT. Now, I talked about before how, when we report a sinonasal mass, it's important to do tumor mapping and staging. And this is a very busy slide. And most of the sinonasal neoplasms, we're going to use the AJCC tumor staging. And a couple of things I do want to point out is, I'm not going to go over all the details of this. But when you're looking at a mass, they divide into maxillary sinus, a nasal cavity, and ethmoid sinus. So that's one thing to first determine is whether you think the mass is arising in the maxillary sinus or the nasal cavity and ethmoid sinuses. And a couple of things I did want to point out is, okay, involvement of the medial floor and wall or floor of the orbit, that automatically makes get T3. Another thing that I always check is the orbital apex. Involvement makes it T4B. The lymph node status is similar to other head and neck neoplasms. And if, it's rare that these paranasal sinus neoplasms metastasis to cervical nodes, but when it does happen, it has a poor prognosis, and the highest qualifier is N3B when there's extranodal extension. So now I'm going to go through all the ones that I listed in the outline. And the first one I'm going to go over is hamartomas. These benign entities most common ones are going to be respiratory epithelial adenomatous hamartoma, RIA, and the serum mucinous hamartoma. RIAs are often bilateral, so suspect them when an olfactory cleft measures greater than 1 centimeter on the coronal CT. So here's an example of a RIA, and this is, you can see that there's widening of the bilateral olfactory clefts. Here are trapped secretions in the left frontoethmoidal recess, and on FDG PET, there was no FDG avidity. Versus serum mucinous hamartomas are typically unilaterally, and this mass arising from the posterior nasal septum. Sinonasal papilloma is another benign neoplasm I want to talk about. These are benign neoplasms arising from the Schneiderian epithelium with malignant potential. The characteristic site of origin is the lateral nasal wall near the middle turbinate. There's a male preponderance, and there's 3 subtypes. Inverted papilloma is the most common. That's what you've probably heard of the most. Exophytic and oncocytic, which is the least common. I'll talk more about inverted papilloma just because it's the most common. And one thing I wanted to highlight is 95% of the time, you can see focal hyperostosis at the attachment site of the tumor or intralesional calcification. And this is important because it's important to note this if you see it, because the surgeon needs to resect this part to ensure complete resection. Another imaging pattern that you've probably heard about is the convoluted cerebriform pattern. It's alternating linear or curvilinear hypointense and hyperintense signals on T2 and T1 post-contrast. It's non-specific, but a lot of times this is associated with inverted papilloma. So how do you tell when there is malignant transformation? Concomitant malignant transformation to squamous cell carcinoma. A couple clues. If you see focal loss of this convoluted cerebriform pattern of enhancement, you see intratumoral necrosis, aggressive bony erosion, or extrasinonasal extension. Another imaging pattern that is helpful if you see it, if you see this convoluted cerebriform pattern and it's hyperintense on T1, that can typically be seen with the oncocytic subtype. So here is an example of inverted papilloma. We can see that there is a left sinonasal mass, and on the T2 and the post-contrast, we can see that convoluted cerebriform pattern of enhancement that we typically see with inverted papilloma, and you kind of imagine that this arose probably in the lateral nasal wall near the middle meatus. Next, I want to talk about benign entity, benign neoplasm is sinonasal tract angiofibroma or juvenile nasopharyngeal angiofibroma. It's rare, benign, locally aggressive, highly vascular sinonasal tumor, 0.05% of head and neck tumors. And the main demographic, or what you see on test, is going to be an adolescent male that presents with epistaxis. You'll see a unilateral mass centered in the sphenopalatine foramen, widened to pterygopalatine fossa, characteristically bows this posterior wall of the maxillary sinus forward. On the MRI images here, we typically see intense hypervascular enhancement and see flow voids on both T1 and T2 imaging. On angiography, typically embolize the IMA before performing a resection 24 to 72 hours before to decrease bleeding. And when you see these, you typically don't biopsy them because there's risk of bad bleeding. And these patients can get adjuvant radiation for unresectable intracranial disease. Another entity I want to talk about in terms of the benign neoplasm is ameloblastoma. This is the second most common benign odontogenic tumor. It's locally aggressive. The typical demographic is going to be middle age and presents a hard, painless mass near the angle of the mandible 80% of the time and maxilla 20% of the time. When it does occur in the maxilla, it can encroach into the maxillary sinus and present like a sinonasal present as a sinonasal mass, and there's high rate of recurrence, and when it's large, can erode through bony cortex into soft tissues. It rarely metastasizes, and when it does, it can metastasize to the lungs. So on CT, typical appearance is going to be a multiloculated, expansile, solid and cystic soap bubble appearance with well-defined thin border associated with an unerupted tooth in the premolar and first molar region. So here is an example of a ameloblastoma, and we can see that here is the unerupted tooth. We can see this well-defined thin border here. And then on the axial CT, even though I think this image is without contrast, you can see that it looks like there's a solid cystic appearance. And then we get the MRI, and that confirms it. MRI, it can have a mixed solid and cystic pattern with irregularly thickened walls and avid enhancement of the solid component. So here's the solid and surrounding cystic component and avid enhancement. All right. Now we're going to move on to the malignant lesions. I'm going to start out with sinonasal squamous cell carcinoma because it's the most common. It represents 61% of sinonasal malignancies. Majority occur in the maxillary antrum. It has a male preponderance. 80% demographic-wise, 80% older than 55 years old in presentation. And there are some occupational exposure risks: leather dust, chromium, arsenic, asbestos, and welding. It is divided into keratinizing and non-keratinizing. The keratinizing type typically arises from the nasal vestibule, and the non-keratinizing type is associated with HPV type 16, and those has improved overall survival. And when I talk about how molecular testing has really kind of changed things in the last 5-10 years, here's an example. On the non-keratinizing, there's DEC-AFF2 subtype that has a propensity for the posterior part of the middle terminate. And this has a low-grade papilloma-type histology. Even though it looks low-grade, it has an aggressive clinical course, has frequent local recurrence and distant metastasis. And this is the age of precision medicine that we live in, that when we do this kind of molecular testing, even though on histology it looks low grade, we can predict the clinical course. So imaging features of squamous cell carcinoma: bony destruction, extensive local regional invasion with perineural spread, orbital intracranial intensity, intermittent signal intensity on T1 and T2, and low ADC because it can be highly cellular and can metastasize to cervical and lateral retropharyngeal lymph nodes. And this is the case I've already shown previously, the left sinonasal carcinoma, and this has the local regional invasion, intracranial dural invasion. Another fairly newly entity that is described is HPV-associated multiphenotypic sinonasal carcinoma. It previously, in the WHO 4th edition, was called HPV-related carcinoma with adenoid cystic-like features. It's associated with high-risk type 33 HPV and has propensity for the nasal cavity, specifically determinants, lacks propensity for perineural tumor spread, and despite the aggressive imaging and a histologic appearance, tumor has indolent behavior, regional spread, and distant metastasis are rare. So this is in a contradiction to that DEC-AFF2, where this looks aggressive, but we know based on this molecular testing, if the pathology comes back as this, that it has indolent behavior. Next, malignant cytokine neoplasm is I want to talk about is adenocarcinomas. And adenocarcinomas are in the cytonasal region, are divided into salivary and non-salivary types. Salivary, most common, is going to be adenoid cystic carcinoma. Others include myeloepithelial carcinoma and acidic cell carcinoma. So adenoid cystic carcinoma is the second most common sinonasal malignancy after squamous cell carcinoma. Typically occurs in the maxillary sinus or nasal cavity. Has poor prognosis because it's very well known to have local and perineural tumor spread. Here is an example of adenoid cystic carcinoma and the perineural tumor spread that it can exhibit. You can see here on the T1 imaging, there's involvement of the pterygopalatine fossa with the white arrow. And then here on these additional fat-sat post-contrast images, you can see that the perineural tumor spread in the Vidian canal, foramen ovale, foramen rotundum, inferior orbital fissure, and superior orbital fissure, orbital apex, and the cavernous sinus. In terms of the non-salivary adenocarcinomas, they are divided into intestinal and non-intestinal. The intestinal is the second most common after adenoid cystic carcinoma, and it's named that because it histologically resembles carcinomas of intestinal origin. They're aggressive, and have a predilection for the ethmoid sinuses and can locally spread to the orbit, pterygopalatine fossa, and cranial cavity. Here's an example in the literature. We can see that there's there's a sinonasal mass centered in the right ethmoid air cells. And we can see that T2, there is a low signal that could represent high cellularity or hemorrhage. On the post-contrast, you can show here are the retained secretions. This is the actual mass, and it has enhancing solid components, but there are also areas of necrosis. Non-intestinal subtype is rare, heterogeneous, has a diverse morphological pattern. It also has a predilection for the ethmoid sinus and has poor prognosis. Now let's talk about bony origin masses. Chondrosarcoma is a malignant cartilaginous tumor, 10% in the head and neck. Predilection for the maxillary sinus typically occurs in 4th to 6th decade of life. And this is a case I've already shown before. We can see the characteristic ring and arc osteoid matrix, appearance of the chondroid matrix and bony destruction, and typically has low to intermediate signal on T1. We can see that here on the T1 images. Has high signal intensity of the non-calcified cartilaginous portion on T2, demonstrated here. And on the post-contrast, it has this variegated enhancement and actually has increased ADC value, so no restricted diffusion. And we can see that here on this image. Here's an example of osteosarcoma. And we talked about how it's a hyperdense mass with osteoid matrix and this sunburst periosteal reaction. Has a predilection more to the mandible over the maxilla, and a higher incidence in hereditary retinoblastoma, and it may arise in bones affected by Paget disease. Here is a case of radiation-induced sarcoma. You can see this was a young adult and had childhood retinoblastoma, had the right orbital exenteration. Here's the prosthesis. And we can see here this sinonasal mass on the right. These are the trap secretions, and we see heterogeneous enhancing mass here in the right ethmoid air cells. So now I want to move on to neuroendocrine malignancies. First one to talk about is going to be olfactory neuroblastoma or esthesioneuroblastoma. It is a malignant neural crest tumor originating from nasal cavity's olfactory epithelium. Has a bimodal distribution of 20 to and 50 to 60-year-old. On CT, it typically occurs as a homogeneous soft tissue attenuation in the superior nasal cavity, has adjacent osseous erosion. And on MRI, there can be cysts at the intracranial margin that are highly suggestive, but not specific. It's actually relatively uncommon. It has no bearing on the tumor grade. But this is, something that we do learn about these intracranial peritoneal cysts. T1 can be hypointense. On T2, ISO to hypointense compared to the gray matter and enhances heterogeneously. It can metastasize to lungs, bones, and spinal involvement and liver involvement. So one thing I want to talk about is that we had talked about the JCC cancer staging, but this is the one exception. It has its own staging system, the Cartilage staging system, where originally proposed stage A would be tumor confined to the nasal cavity, and then B would be tumor confined to the nasal cavity and paranasal sinuses. C, tumor extends beyond the nasal cavity and paranasal sinuses, including the cribriform plate, skull base, orbit, or intracranial compartment. And then in the 90s, Morita et al. Proposed a revised and the modified Cartilage staging system, stage D, has regional lymph node or distant metastasis. So here's an example of Cartilage group B. We can see here that there's tumor confined to the nasal cavity and paranasal sinuses. And we can see again this example how here just a pacification on CT, but here we see the blue is pointing to the tumor, and here superiorly we have trap secretions. Good for tumor mapping. And then here is type group C. There's tumor extension beyond the nasal cavity and paranasal sinuses. So we see this aggressive, fairly midline sinonasal mass, and we can see that there is, invasion into the dural invasion that makes it the Cartilage group C. And here's a little additional mass in the floor of the right maxillary sinus. Another neuroendocrine type sinonasal malignancy that you've probably heard of is sinonasal undifferentiated carcinoma, SNUC, a very highly aggressive, rapidly growing malignant tumor. If something looks very aggressive, I typically will include this in the differential. Arises in the nasal cavity or ethmoid region. On CT, greater than 4 centimeters, osseous destruction, local regional invasion. MRI, iso-intense on T1, hyper-intense on T2 compared to the muscle, enhances heterogeneously. And again, the MRI is really good for tumor mapping, high propensity for orbital and intracranial invasion and perineural spread. So here we see that this sinonasal mass on the right that came back as SNUC. And again, we can see that the MRI really helpfully to show that this is traps secretions with mucosal thickening, and this is the actual tumor here, and there are areas of enhancement and necrosis. Another example of where molecular testing has really helped is these tumors can be tested for IDH2 mutations, and these patients have a 50 to 80% better prognosis than those with the wild type gene. So yeah, we're not talking about intracranial glioblastomas, but with these SNUCs that they can also now do IDH mutation testing and tell the prognosis. One of the newer entities is this nuclear protein of the testis nut carcinoma, and it's an aggressive variant of SNUC. And so I think SNUC used to be kind of a wastebasket diagnosis, and we're going to see that less with molecular testing and be able to put them into these different subtypes. Has a propensity for thorax and head and neck. It presents as an expansile necrotic tumor with local invasion in cervical lymphadenopathy and osseous metastases. On CT, can have bony erosion and hyperostosis, avid contrast enhancement, intralesional mineralization, and orbit invasion. So here is an example that I showed previously of this mass, and it has that intralesional mineralization that is described. MRI can have T1 hypointensity, T2 hyperintensity, and enhanced with central non-enhancing component necrosis. So again, here I keep outlining this. These are the trap secretions. Here's the actual mass, and then there are areas of necrosis, enhancement, necrosis. This is also another one of the newly described entity, SWI-SNF complex deficient carcinomas. And it was previously described as this SMA-ARC-B1 deficient carcinoma, but then we found that you can be defined by loss of more than just this. Also, SMA-RCA2, SMA-RCA4, and so that's why now it's kind of this is the new name. So highly aggressive, presents late stage, nasal and nasoethmoidal region, local invasion of orbits, and intracranial. So CT can have intralesional calcification, adjacent hard end periosteal reaction. Here with CT, we can see that there's osseous destruction. And then on the MRI, T1 iso-intensive gray matter, variable signal intensity, variable degree of homogeneity enhancement, and moderate restricted diffusion. And so here, variable T2 signal, variable enhancement, and then here's the restricted diffusion. Sinonasal neuroendocarcinoma is a highly aggressive malignant tumor, has a high recurrence potential, share common site of origin with SNUC, particularly ethmoid, 5th to 6th decade of life, isodense to mildly hyperdense, moderate to marked enhancement, bony erosion, ill-defined border, T1 iso intense, T2 mildly hyperintense, mild to moderate homogeneous advancement, and invasion into adjacent structures such as orbits, superior and inferior orbital fissure, pterygopalatine, fossa, and optic canal. So at Tumor Board this week, we had a case of this where, it was a mass that looked like a olfactory neuroblastoma, in the nasal cavity, nasal vault, extending into the intracranial, and initial preliminary path showed it was a neuroendocrine type tumor. And so what's brought up at the tumor board, okay, on the final, is this olfactory neuroblastoma? And the pathologist said no. So it's more like a small cell tumor, and I think would be in keeping with this type of sinonasal neuroendocrine carcinoma. And then lastly, going to be the sinonasal mucosal melanoma, highly metastatic, 1% of malignant melanomas originates in the nasal cavity, nasal septum, 40% neural metastases. These can have discordant imaging and biological behavior where they can look very well defined, non-invasive appearance, but actually be very aggressive. So they can have bony erosion, T1 hyperintense hemorrhage and parakinetic effects of metal ions attached to melanin. So this is a characteristic thing to look for. T2 hypointense, intermediate signal across all MRI, can have perineural spread, and that might be linked with prolonged period of latency. So here's an example here in the right nasal cavity, and on the T1, you can see that there is that T1 hyperintense melanin. But, we got to be complicated. And here is a melanotic melanoma. You can see it's quite aggressive, extending in the orbit, extending in the premaxillary soft tissues. But on the T1, it's dark. There's not bright T1 signal. So you can get, not everything is absolute. You can have a melanotic melanomas. And then I didn't want to not talk about sinonasal lymphoma. Head and neck is the second most common site of extranodal lymphoma after GI tract, less than 10% in the sinonasal cavity. Nearly all are going to be non-Hodgkin lymphomas, B cell, T cell, natural killer cell, or T cell NK precursor cell phenotype. And in the West, they're mostly going to be EBV negative, diffuse large B cell lymphomas. And in East Asia and South America, more likely going to be EBV positive T NK cell subtype. On CT, you're going to have bulky, ill-defined soft tissue mass with bony destruction and soft tissue invasion. In MRI, heterogeneous intermediate signal on T1, T2 with moderate enhancement and restricted diffusion. And here's a case here, this right sinonasal transspatial mass invading the orbit, and here's that characteristic restricted diffusion. And now I talk mostly about CT and MRI for characterizing these lesions. If there's suspicion for distant metastasis, FDG PET and dotatate PET are two types of nuclear medicine imaging that we can do. FDG PET is going to be better for epithelial malignancies. So this is a patient with adenoid cystic carcinoma, and here we see the distant PET in the pelvis. And this here on the right is a patient with olfactory neuroblastoma, so neuroendocrine tumors are going to be better to be used for dotatate PET to look for distant metastases. So in conclusion, CT, if you see something that has osseous erosion, think aggressive malignant process, bony remodeling, long-standing is going to be more of a benign process. It could be a benign neoplasm. MRI is going to be good for tumor mapping to help with staging. Look for dural invasion. Look for infiltration of the periorbita, that hypointense zone. Look for perineural tumor spread. Even though I talked about so many entities, squamous cell carcinoma is still the most common malignancy, and most common site is going to be the malignancy is the maxillary antrum. Adenocarcinoma has the predilection for the ethmoid sinuses, and I talked about some of the newer entities out there, like HPV-related multiphenous carcinoma, which has an aggressive appearance but indolent behavior, versus this DEC-AFF2 fusion subset of squamous cell carcinoma has low-grade histology but aggressive clinical course. A couple, things to look for with inverted papillomas, looking for that focal hyperostosis at the attachment site of the tumor, so the surgeon knows and can do a complete resection. I talked about the variants of SNUC now that are newly described, SWI, SNF, complex deficient, and NUC carcinomas. So I think you'll see less of that, less SNUCs being called in because we have these different subtypes now with molecular testing. And in SNUCs, if you, they could test for IDH mutations, 50 to 80% have a better prognosis than the wild type. And don't forget, with olfactory neuroblastomas, they have their own staging system, the modified CADIS staging system. Sorry, I went a little over time, but thanks for your time. And if anybody has any questions, I'm happy to answer them.
Thank you so much, Dr. Hsieh, for that informative presentation. We can actually move on to our discussion session. So below in the toolbar, there's a Q&A button. You can put your questions there, and if there's any questions, I'll read them out. And I guess while we're waiting for that, Dr. Hsieh, when you're presenting on the olfactory neuroblastomas, I know you said MR is a pretty good modality for evaluating dural invasion. My question is, are there any specific reliable signs for differentiating dural invasion versus just reactive dural enhancement?
Yeah, so if it's kind of thin enhancement, then that could be just reactive. And a couple of things you want to look for on that T2, you want a nice correlate T2 sequence, and you want to look for that breach of that hypointense zone. If it's nodular, thickened, greater than 2 millimeters, then those are all things that you can be fairly confident and say, okay, there is dural invasion.
Okay, understood. I don't see any questions. I'll give it another 10, 20 seconds to see if any filter through. I think there is a question coming through. I'll read that out.
Yeah, it's a good presentation. Are there any specific, and then it just kind of ended there. Oh, signs for differentiating the subtypes in the absence of molecular testing. Yeah, I think that's probably an area that can be researched more. But there are, yeah, like even with that nut carcinoma, that intralesional mineralization. But again, a lot of these signs are non-specific, and you've probably noticed there's a lot of overlapping patterns. So unfortunately, when we see a lot of these things, we have to provide a differential and wait for the pathology. So yeah, not that I know of anything really specific, and that's definitely an area for further research. Like, yeah, I just found it really interesting that, like with, glioblastomas, we do the IDH test for the IDH mutation. Now they can do that for sinonasal masses and help to determine if your prognosis, help determine prognosis. So, yeah, I mean, truly in the age of precision medicine.
Thank you so much, Dr. Sheen. It was such an amazing lecture.
Thank you for your time. I hope everyone learned something.
Yeah, for sure. Thank you so much, Dr. Kevin, for an awesome moderation. Yeah,
Thank
I
you
do
for
not see any more
everyone's time,
questions
and
as well.
have a good weekend.
Yeah, you too.